Now I like to invite Dr. Revathi Madam, who is my teacher also. She will be talking about the effective treatment strategies for challenging organisms. Over to Madam.
I am going to walk through some case examples of some normal infections which presented differently, or some rare infections, and how we managed. And first let us start with multi-drug resistant pathogens. This we have to keep in mind. They are not that rare nowadays. Their incidence is increasing, especially if infection occurs in a healthcare worker. So nowadays more of post-LASIK infections are due to this multi-drug resistant organisms. It can be anything, like it can be in pneumococci, it can be in Staph aureus or MRSA, or it can be gram-negative organisms also. So these pictures are from Dr. Lalita's work in Madurai, and you can see in pneumococcus about 2.4% of isolates can be multi-drug resistant, and they are not responsive to ciprofloxacin and fluoroquinolones. So that we have to keep in mind when treating them empirically with fluoroquinolones. And the same way in Staph aureus also, 76% of these organisms are MDR, and they are 100% resistant to fluoroquinolones. And coming to Pseudomonas also, same thing, and their response to this fluoroquinolone again is very, very less. So multi-drug resistance, they are not responding to common therapy. So we have to keep in mind, and 2 drugs or 3 drugs which stand out here: chloramphenicol, vancomycin, and the ceftazidime. So when in bacteria, the response will be usually good. When it is not like that, then immediately think about multi-drug resistant and try to get a culture sensitivity pattern. If not, go for these drugs. And on the other hand, don't use vancomycin and ceftazidime as the first line therapy in case of infections, because those are the few drugs we have for multi-drug resistant organisms. Coming to the other ones, the deep fungal infection. This is a case where a 57-year-old male, only thing he had as a systemic problem is he is on steroid inhalers for his asthma. Other than that, he is not a diabetic, a very healthy person, already treated as fungal for 2-3 weeks in a different place. When he came here, the surface was healing, but a deep infiltrate and endothelial plaque kind of thing was there. So we have started intrastromal injection, voriconazole. After 2 or 3 injections, he started responding very well. And we even scraping, we couldn't find anything because it's all deep infection, and only with confocal we could find that it is definitely fungus. And 5 days later, he went back, and he came back with again the vision dropped and worsening of symptoms, and 2 new satellite deeper infections started, infiltrations were seen. IOP also started rising, and here we started oral voriconazole for him, because at this time we scraped and the culture came as Fusarium. And after 3 weeks of therapy, he started responding very well, as you can see here. And he stopped. We planned initially to give oral voriconazole for 3 weeks, and he stopped the medication. Again, the symptoms started worsening, and as you can see, even in the AIOS2025, you can see the deep endoexudate extending towards the periphery. So an alarming sign. Again, we restarted the oral therapy along with the topical therapy, and he started responding. After 8 weeks of therapy, it completely healed, and he has become clear of infection. But here the 2 points from MUT2, what we have learned. Oral voriconazole sometimes can be an additive, a good additive for topical therapy in case of Fusarium. And the repeat culture after 1 week of therapy came as positive. That is again an ominous sign. So we have to, in these cases, we have to treat aggressively. Other rare infection I want to here share with you. 2 cases, both young female, presented with no predisposing factor, just an chronic ulceration with severe photophobia, and you can see not much of necrotic lesions. It looks more superficial with a lot of inflammatory reaction. And in this picture I am not able to show you, but in the posterior part of the endothelium as well as the anterior chamber, a fibrinous pigmented lesion was sitting there. So we thought more towards the fungal, and both cases were treated as keratouveitis and with oral and as well as topical steroids also. And this actually, this two picture I borrowed from Dr. Radhika from Shankar Netralaya. She has seen a case like this and published also. As you can see, this is the picture what we have seen in our patient also, a endothelial plaque which is going even up to the anterior lens capsule. And this alerted us, and the scraping came to our surprise as atypical mycobacteria. No previous predisposing thing, anything here. So we have after consulting with infectious disease person, we have started around oral clarithromycin also, along with topical clarithromycin and amikacin and minocycline. And he advised us to go ahead with the treatment for at least 8 weeks. And we have done that, and she completely responded after 3 months, completely cleared. The similar way, in few weeks time, another female we have seen with the same picture, but with a history of some fall of insect. Again, the culture report came as atypical mycobacteria, and here we straight away started the oral clarithromycin, and then she also started responding, and we have given it only for 3 or 4 weeks, and by the time she healed completely. So we have to keep in mind, in atypical mycobacteria always need not be a typical picture like this. It can be even without any predisposing history, and once you recognize that, no steroid for these patients, and oral therapy is really helpful in these patients. And microsporadial keratitis, again we all know, microsporadial stromal keratitis is very difficult to recognize and often mistaken for viral, but the typical clinical picture will be a granular infiltration, some mistiness in the stroma without any necrotic lesion, and this will keep on spreading. And this young female, she is on for immune nephritis, she was on oral steroid already, so very less toxic reaction and only inflammatory reaction, only this kept on spreading. And the confocal picture, you can see the typical rice-like bodies within the intracellular bodies. This is a very typical histopathological like kind of picture. And we went for, because we have to plan for a surgical intervention, we went for a corneal biopsy to prove it, and it came as positive for rice bodies. And then we went ahead and did a large therapeutic DALK here, because we have to go up to the limbus. But at present she is okay, but in these cases sometimes the recurrence can come, and she may need a full thickness keratoplasty later. It is possible, being reported from other centers. The last one is acanthamoeba challenge, what we are seeing nowadays. Handful of cases I have with immediate scleral invasion, and they are behaving very badly, and it's not like the usual acanthamoeba, so slow smoldering infection. They progress very fast. This is one young boy with contact lens misuse. He came with this, and within a few days the picture became like this, and it was going towards the superior limbus. So actually here also we have to go for a lamellar cut and take the material from deeper layer to prove that it is acanthamoeba. And then we have started him on 0.08% PHMB, which is being recommended nowadays. And in addition, because this infection is so bad, I have added double biguanide, another chlorhexidine also, and also oral voriconazole, which is being recommended by Dr. Elmer too from UAC. Because here I want to try everything possible to save this boy's eye. And finally he started responding, and even AIOS2025 picture also started recovering well. Now after tapering the biguanides, the vascularization also came down very well. So then why we have to be aggressive? This is another example, another young man. A picture was like this, well demarcated also. We went ahead with a therapeutic graft, but what we are seeing is a non-healing ED, and again a reinfection. And not only that, a severe cyclitic membrane in the he developed, and the eye was started going towards thysis bulbi. And then we repeated the graft, and we have injected a silicone oil, and we are trying to save the globe for him. And the scleral invasion also occurred immediately after that, before the SOI. So nowadays, I don't know, the last few months we are seeing acanthamoeba in a very aggressive manner. So the reason may be from the initial infection, it can be a inflammatory response. The scleritis, Diffuse adenitis we have seen in a young lady, and sympathetic ophthalmitis also being reported. Or it can be intense parasitic invasion itself, which can cause all these things, scleral abscess, endophthalmitis. We have seen a series of post-op endophthalmitis after acanthamoeba. And so these things can occur in acanthamoeba, and acanthamoeba not always a ring abscess which is there sitting for months together and being treated as viral keratitis. The picture can be very different, and sometimes we have to be very aggressive. And not only that, the toxic reactions like cataract, anterior segment ischemia, or even posterior segment ischemia can occur due to either the toxin released by acanthamoeba or the drugs itself. So sometimes we have to go aggressively for acanthamoeba treatment. So in conclusion, keep rare infection also in mind when the response is not what you expect. A methodical microbiological workup is very, very important. And we always think about multi-pronged therapy when the response is not good, oral and other therapeutic options also. Thank you.
Any questions from audience for ma'am?
Sir, biguanides only, either chlorhexidine or PHMB. And the recent report from Moorfield suggests that 0.08%, because previously we used to use 0.02% or maximum 0.04%. But now Dr. Dart and his team reported that 0.08%, if you start with aggressively, then the response will be better. But that's what we are even now studying as a randomized controlled trial. But what I observe with 0.08, there is some definite drug toxicity is there. And this handful of patients whom I have seen recently, they are, even when they come only, they are very aggressive. Within few days I can see the scleral involvement. So I don't know, now the acanthamoeba, I feel it's behaving differently. But the first line of therapy will be one of the biguanide, either chlorhexidine or PHMB. Yes, that we have to get the medical grade. I think Lalita will.
Yeah. Actually, Orolab is now, it's available in Orolab. If you go to the Orolab website or contact some Orolab dealer, they are selling the concentration as 100%. I don't know whether they're selling it as a diluted. Are they selling it as diluted one?
Reconstituted. Powder will come.
No. They sell it in the solution. So it's just very easy. You just have to just take 20 microliter of the drug and just mix it in 20 ml of distilled water. So that is for 0.02%.
Okay.
So 0.04 means you just double it. So just 20 drops. If you don't have a micropipette, just take 20 drops of the drug in 20 ml of distilled water.
Okay, thank you.
And it's available in Orolab is giving it.
Because I'm practicing in a small town, sometime facility of culture and all these are not available. And many patients came with so many taking treatment from rural areas, different drugs. So what should we prefer in that case? In bacterial, sir, multiple means.
Bacterial ulcers.
Yeah.
If already they are on multiple drugs, generally what I would advise, you first stop all the medication and see, and maybe like if you are very convinced it's bacterial, just start with, usually if it is a significant ulcer, you have to go for a fortified cephalosporin or something which are relatively less toxic, and start that, and then you see the response. Accordingly, like if necessary, you can add any other drug. Otherwise, it's better not to allow them to continue with multiple drugs. Sometimes the drug toxicity itself will not allow the ulcer to heal.
Will it be means ceftazidime and amikacin both we
No,
can give?
ceftazidime you always preserve for multi-drug resistant pseudomonas. Cefotoxime will do.
Okay.
Cefotoxime, amikacin we can use.
Okay. And what about tobramycin?
Tobramycin also we can use.
We are making fortified preparation. In 3 ml vial, we are injecting injection
Injectable
of
form.
tobramycin or amikacin.
Yes. That we can use. Yeah, Tobra also equally good only.
Thank you, ma'am. Thank you.